Go ahead and start it. There we go. Now we're official. And Dr. Grimes is joining us too. Good to see you, Tiffany. So anyway, I'm going to just really actually introduce Brian, who can introduce everyone else. Brian is over at HHS and works with Elliot Kennedy, among others. Elliot was, I guess, on vacation now or not otherwise available. So by virtue of the out of office message I got and my follow-up, Brian very dutifully took over the role of helping us put together this panel. As I was telling our previous group, Thursday has traditionally been our Go to Capitol Hill day, and we would usually start by going to the Humphreys building and spending time with the folks at HHS and the ones that you assembled. Then we'd go to the Hill and usually meet with Senator Baldwin or Congressman Takano or Ted Lieu or something like that. And then we'd end up back at Woodman Walker. We are all virtual this year with any luck for the last time. And I really appreciate your taking the time to put together what looks like a really stellar crew. But Brian and company will be sort of leading us through on the federal side, what's going on with HHS and the bureaus, other bureaus related. So HRSA and SAMHSA, I know represented here, for instance. And he'll kind of walk us through what the priorities are, what's going on. I think we'll get a horror story or two about the past 4 years along the way, and probably focus more on the future and what's positive and what we have to look forward to going ahead. So Brian, I'll kick it over to you, and thank you again for coming.
Oh, sure. Thanks, Steve. And it's I just want to say it's been a wonderful partnership of the years. I can't remember the first meeting in the Humphrey building where you said, I'm starting this thing and we really want HHS to be part of it. And we're like, oh yeah, that'd be amazing. And you're like, please tell people about this program. And then ever since, at least in the years that I have stayed within federal government, I have participated in the panel, mostly in the past, as some of you may know, from the SAMHSA side. But it's always a great opportunity to share what's going on at HHS, as well as hear from students in the field about where they think policy and practice-wise we might be missing some information or some key priorities, et cetera. So just really appreciate the partnership, Steve, and the opportunity to speak with you. I would say, I won't give any horror stories, but I would say that it's definitely wonderful to be back in a situation where this panel from HHS is made up of both political and career staff. And that support is there from all aspects of the department. So we obviously have folks working on LGBT issues across all of the staff and operating divisions within HHS. Operating divisions are sort of those that provide programs and administer different entities like the National Institutes of Health and the CDC, et cetera. Staff divisions are those that support the secretary in multiple ways. And so we're going to start with Dr. Saki, who is with the Office of Global Affairs, and then Ms. Boughton, who is with the Office of the Assistant Secretary for Health. We could not be more pleased, not only with her, but obviously with her boss as well, Dr. Levine, the first openly transgender Senate confirmed official. And then we're going to turn from the staff division side to the operating division side. I'll speak a little bit about the work I currently do at the Administration for Community Living. And then Jim Doss is a longtime LGBT point person for HRSA, the Health Resources Services Administration, and he can talk about the work there. And finally, Umberto Carvajal is going to talk about some of the work taking place at SAMHSA, the Substance Abuse and Mental Health Services Administration. And then we hope we're each going to talk hopefully somewhere around 7 to 10 minutes, and we've left for about 15 to 20 for questions at the end. And the last thing I'll say before I turn it over to Dr. Saki is just that I think some of us have slides, or at least I know Umberto does, others of us don't, but if there are websites or links that you heard us talking about and you want more information on, I sort of can reach back to the panelists after this and get a collection of websites or other resources that they might mention that might be helpful moving forward. So with that,
I made Umberto a co-host, so you can share your slides, Umberto. And if anyone else wants to share slides too, let me know, and I just need to make you co-host so you can do that.
Okay, great. So with that, I think we're going to turn over to Dr. Saki because I'm not sure if she can stay the whole time, but the rest of us can. And if you have questions for her at the end, we can sort of send them to her and she'll get back to you afterwards.
Thank you so much. And actually my 1 o'clock meeting was shifted later, so I have a little bit more time, but I'll stay as long as I can. So thank you for the invitation. I'm really happy to be here and so happy to be working for an administration that places priority on the issues that we're talking about today. So you might all have some of this background, but I thought I would start by telling you what the Office of Global Affairs does within HHS. So OGA, the Office of Global Affairs, leads global health diplomacy efforts for the US government. So what does that mean? HHS, as you probably know, is essentially the counterpart to ministries of health around the world, even though the way that HHS works and the healthcare system in the US works is very different from the way that it works in most other countries that we work with. Specifically in most countries, the US government is providing healthcare for most of the population. And so that's a big difference in terms of the scope of HHS's reach, but we still are the counterpart to ministries of health around the world. So we at HHS partner with colleagues in ministries around the world, often through multilateral institutions like the World Health Organization, to develop and implement public health policy. And part of how that role plays out, and I know we'll hear from other colleagues at HHS, is that the US often offers technical expertise in these partnerships through CDC, NIH, FDA, and other parts of HHS. So OGA coordinates a lot of this work for HHS, and we also collaborate with colleagues at other agencies in the US government who work internationally, especially the State Department, USAID, and the National Security Council at the White House, to try to prioritize, advance these issues that the White House has told us they want to focus on. So as you may know, in February, the president issued a memorandum on advancing the human rights of lesbian, gay, bisexual, transgender, queer, and intersex persons around the world. And you can find the full text of that online. I'm happy to share it in the chat as well. And this really fits in squarely to the priority that the administration has placed on equity broadly, including racial equity, making sure that services are provided to groups that have historically been marginalized and underserved, gender equity and equality, and a lot of other ways that plays out, thinking about the COVID response and equity within the COVID response, for example. So under that umbrella, in February, the president issued this memorandum. And through the memorandum, the president said that he is directing all agencies engaged abroad to ensure that US diplomacy and foreign assistance promote and protect the human rights of LGBTQI+ persons. So there are a lot of different components of this memorandum, but I think because it's been such a top priority and it's been so well organized, in my opinion, from the National Security Council and coordinated within the US government, it has really shaped a lot of the work that we're doing internationally, at least from the perspective of OGA. So I thought I would just touch on a few pieces within a few sections of that memorandum and talk about how our work is playing out right now within those sections. So one section is on rescinding inconsistent policies and reporting on progress. And this is relatively smaller in scope in terms of overarching policies, but it's just taking a look at the policies of the previous administration that affect HHS work abroad and communicating clearly or changing regulations to make sure that those no longer apply in ways that might violate the terms of this memorandum, so specifically violate the rights of LGBTQI+ individuals around the world. So the most relevant policy that we rescinded was the Geneva Consensus Declaration. And in our, I don't know if you're familiar with it, can share a link to that, but I think probably it's time to move forward and look toward the future. But in our rescission of that declaration, we stated very clearly, and this was shared by the State Department in collaboration with HHS, that pieces of that document are not consistent with the administration's policies, including those related to LGBTQI equality around the world. And so there wasn't really funding attached to that policy, but we wanted to make sure that that's no longer, it's clearly communicated that that's no longer where the administration stands on these issues. So another section of the memorandum, just to touch on, which has pretty broad implications for HHS and other colleagues might touch on this as well, is foreign assistance to protect human rights and advance non-discrimination. So thinking about foreign assistance, and there actually is quite a bit of foreign assistance funding that flows through HHS. Most of it goes through CDC. So thinking about foreign assistance, there are a few pieces here. So one piece, again, is actions like rescinding policies such as the Mexico City policy that had wide-ranging implications for current foreign assistance funding. So that's something that can be done pretty much overnight in terms of issuing an executive order or a memorandum, and the regulations change for existing funding, and then what the money can be used for changes almost immediately. So that's kind of a short-term outcome. But I think the larger, kind of more difficult, longer-term piece is thinking about how we invest the money that we have for foreign assistance, and do we shift priorities? Do we make different choices in order to advance the rights of LGBTQI individuals abroad? And as part of that, make sure that we are protecting these rights through current foreign assistance funding, even if it's not directly focused on these rights. So some of that work can be done through reviewing our foreign assistance policies, but a lot of it has to do with longer term discussions about the budget and how the budget is divided up and how funding is awarded. So that's very much in process. In the meantime, there is quite a bit of really interesting, important work that's ongoing through NIH, CDC, HRSA, FDA, ORR, and you might hear about some of it from our colleagues, but we just recently kind of pulled together a full list of the work that's happening for an internal report, and it was really impressive and inspiring, I thought. So the third piece of this memorandum, I just want to touch on the third and last quickly, and I think this is where OGA takes the biggest role, is building coalitions of like-minded nations and engaging international organizations in the fight against LGBTQI+ discrimination. So again, we're working closely with colleagues around the US government, especially the State Department, to fight discrimination through bilateral and multilateral partnerships. And a lot of what that looks like is convening what we refer to as like-minded countries, so countries who are on the same page as us in terms of promoting and advancing the rights of LGBTQI+ individuals, and trying to build consensus, especially through the World Health Organization and its regional offices, since that's the relationship that HHS leads on for the government. So in particular, we're thinking about the intersection between these issues and health issues. So for example, what is our role in addressing issues like forced anal exams and conversion therapy that remain legal in a lot of settings and have very clear health implications? So to date, we've met with counterparts in a number.
Can you hear me? Okay, sorry about that. My phone just hung up. Okay, so to date, we've met with colleagues in a number of regional offices, and I think that the good news is there's a lot of excitement about where the U.S. government stands on these issues now, and a lot of interest in collaborating. The more challenging news is that not every country is like-minded, and in particular, I think that the work of the previous administration to really build coalitions of countries on the other side of these issues, frankly, has been very damaging, and it's difficult to recover from that. And I think in some ways we've gone back and are kind of trying to hold the line right now in terms of the language that we're including in multilateral negotiations. So the good news again is that I think within the US government, we're aligned in terms of the goals of trying to advance and promote the rights of LGBTQI+ individuals, but there is some resistance and pushback with bilateral and multilateral partnerships. The last thing I just want to touch on quickly before handing it back over is challenges of this work, aside from the one that I just mentioned. And I imagine that this is relevant for a lot of my colleagues here, but it's amazing where the administration has been on these issues. I think I'm very hopeful. And also, I think it's important to talk about the challenges in being successful as we unroll these priorities. And one of them is just the continued dominance of COVID-19. I think, at HHS, but also, in the US, but also around the world, as we engage with partners, COVID is understandably a top priority for ministries of health in terms of where their resources and attention are going. And as long as, we continue to be fighting this challenge of COVID, it's going to take a lot of attention and resources away from other very important issues. And that includes these issues, but also things like childhood immunizations, addressing gender-based violence. There have been drops in HIV testing. So I'm just sharing this tension. I think it's really important because it's a day-to-day reality in the work that we do, which is that we can have buy-in and agreement on priorities, but especially, I think this is true domestically too, but when we're working internationally, until the countries that we're working with and the ministries of health that we're working with feel like the COVID situation is under control, it's very difficult to move forward and make progress and engage on a deep level on a number of these other issues. And the other kind of challenge, which I mentioned, is just figuring out how to engage with, I think there are some actors in terms of other countries that are just going to oppose the US's perspective no matter what. And, that's just a reality. But I also think that there are a lot of, not just on these issues, but on some of the other issues that we work on, including sexual and reproductive health and rights more broadly. I think there are countries that are in different places in terms of the evolution of, understanding connections with public health realities and thinking about what's possible in their domestic settings. And so for us, I think we are also trying to approach these conversations from a place of humility and partnership, and less from a place of coming in with a strong ideology that we're trying to impose on people, which is a fine line to walk, especially when we're talking about human rights issues. I think we can maintain a perspective that these are important human rights issues and also have a conversation about the fact that we are not there in the US. We're not where we want to be in the US. And a lot of our counterparts are not where they want to be in their countries. So how can we make progress together? So I will just pause there, and I'm really looking forward to hearing more from my colleagues. Thanks again for the invitation.
Thanks, Stephanie. Sarah, you want to go ahead and go?
Sure. Hi, so I am Sarah Boateng. I'm the Chief of Staff at the Office of the Assistant Secretary for Health. So Dr. Rachel Levine is, of course, our ASH. The mission that we have at the Office of the Assistant Secretary for Health is health for all, health by all, and health in all. So OASH is an interesting place in HHS. We are a convener, we're a bit of a connective tissue. So we're a smaller group that sits in the Office of the Secretary. We have large offices like the Office of Women's Health, the Office of Minority Health, HIV policy, and we work to bring the various parts of HHS together, build consensus, and then work with the Secretary to advance his priorities. So advocating for LGBTQ issues has been a personal and professional priority for both Dr. Levine and I. So a little bit about me. I come to this role from Pennsylvania, where I've been the executive deputy of the Pennsylvania Department of Health. And I've worked alongside Dr. Levine in numerous roles that she's had over the years, helping her move forward with her missions and priorities. And, she's just so honored to have the historic appointment to be the first openly transgender individual to be Senate confirmed, and bring her experience from Pennsylvania here to Washington. What she's been focusing on, and then in turn us, is a range of issues. COVID-19, of course, as Stephanie highlighted, remains top priority for HHS and Dr. Levine. Dr. Levine's also taken leadership role around behavioral health and opioid use. So her history is she is been long time interested in that intersection of physical health and mental health. And so, you know, it's a natural space for her, and she spent a lot of time working on the opioid epidemic in Pennsylvania, and is pleased to take a leadership role alongside SAMHSA here at HHS. She's also been working on gender issues broadly. So Stephanie talked about the Gender Policy Council convened by the White House. Dr. Levine serves as the senior deputy on that. We also have the Office of Women's Health in OASH. We run the Title X program in OASH. Title X is the largest family planning program in the United States. Maternal health and the like. As I shared, HIV policy, so we have the Office of Infectious Disease and HIV policy here at OASH, and the Ending HIV plan is directed out of our office. We are building a new office in OASH called the Office of Climate Change and Health Equity, really focusing on the impacts of climate change on individuals' health, and then intentional about the understanding that the impacts of climate change impact different communities disparately, and we need to build a strategy that protects the health of all people in the United States and from the health effects of climate change. And then health equity broadly, of which LGBTQ issues are prominent in, is a priority of Dr. Levine's, priority of the secretary. And she's very proud to lead the HHS Health Disparities Council, which is an all HHS council, looking at issues of health disparities and health equity and moving forward the various pieces of executive orders. As well as join a group that has existed for a long time, the LGBT Coordinating Council. So the LGBTQ Coordinating Council was established in the Obama administration. It has persisted through the previous administration. It persists now. Brian has a leadership role in the council. And so Dr. Levine's been very proud to join and add her voice to that council and represent the Office of the Secretary and the ASH to support the efforts of that group. So I think that, you know, so far what we found in our time since we've been here is, as Stephanie shared, there's a significant amount of work to do. There's both unfinished work from the Obama administration, important policy priorities that, you know, we need to get up and over the line. There's also some work that was done in the previous administration that needs to be undone, and we need to reverse course. I think to highlight some areas specifically that we've worked on there. So we are put forward a Title X NPRM, a Notice of Proposed Rulemaking. We were intentional in that rule to be gender inclusive, to be sure that Title X program and Title X services are equitable and responsive to all. We've also, Dr. Levine was able to add her voice and support to the Office of Civil Rights determination that 1557 applied and protected LGBTQ people. And, you know, in smaller ways, has been able to add her voice and support the Office of the National Coordinator, who, you know, establishes standards for electronic health records, to the importance of SOGI data being available in electronic health records, so that data be able to be transferred amongst electronic health records. So she's really pleased. We're both really pleased to be here and to be tackling some of those issues already and continuing to look and work with the LGBTQ Coordinating Council on issues in the future. Thanks, Brian.
Thanks, Sarah. All right, I'm going to tell you a little bit about the Administration for Community Living and how we work with LGBTQ plus older adults. So I am the Deputy Director of the Administration on Aging, which is a part of the Administration for Community Living. And the Administration for Community Living's mission is to maximize the independence, well-being, and health of older adults, people with disabilities across the lifespan, and their families and caregivers. And ACL envisions that all people, regardless of age and disability, live with dignity, make their own choices, and participate fully in society. Just last month, President Biden's LGBTQ Pride Month proclamation, among many other wonderful statements, noted, quote, many LGBTQ plus seniors who face discrimination and oppression throughout their lives are isolated and need support and elder care. At ACL, we are committed to ensuring that the LGBTQ plus older adults receive the services and supports they need and deserve. So within the Administration on Aging, which I work, we fund primarily formula-based grants to states, which then in turn fund, turn over the money for the most part to local area agencies on aging. And all of that funding is generally under the Older Americans Act. The Older Americans Act also provides for formula-based funding to tribes. So under the Older Americans Act, which this formula-based funding goes to states and then local area agencies and aging and tribes, there are a range of services that are funded. And these services include home and community-based services. So think things like transportation to a medical appointment, home modifications if you need a ramp for your house now that you may be in a wheelchair, or other need of services in that manner, retrofitting of your bathtubs to ensure you don't slip. In addition to home and community-based services, nutrition support. So think congregate meals, meals where older adults can come together at a senior living center, have a meal together, reduce social isolation and have engagement, learn about other health promotion ideas. Home delivered meals, most of you are probably familiar with Meals on Wheels, which provides meals to the home of homebound older adults as well as others. Another category is health promotion and disease prevention. So within this funding category, we fund things like falls prevention programs for older adults who may be more prone to falling, chronic disease self-management programs. So things like helping somebody with diabetes or a mental illness or HIV self-manage their disease. Caregiver support is another category. And then finally, there's a category of services called long-term care ombudsman, which is really a fancy way of sort of saying that we provide funding to states and local area agencies on aging to monitor nursing home conditions and investigate complaints from individuals who are in those nursing homes. So with all of this funding and services going to states and local AAAs and tribes, Congress, through the Older Americans Act and the statute, dictates that obviously we don't have enough funding for all of these services for all older Americans in this country, and therefore we should be targeting those services to individuals in the greatest economic and social need. So you're probably asking yourself, do LGBTQ plus older adults fit into the category of individuals in greatest social need who could be targeted? So by statute, no. Even in 2020, during the last reauthorization of the Older Americans Act, the exact term LGBT individuals or individuals, sexual orientation, gender minority individuals were not added specifically to the statute. However, what was added was a sort of, I will just call a backdoor reference to LGBT individual older adults, in the sense that it said that that states and AAA should plan to meet the needs of a group of individuals that fall into category of resource centers, and we fund Resource Center for LGBT older adults, which I'll get to in a second, and therefore sort of they are included. Even outside of that, for more than 15 years, ACL has stated that isolation due to sexual orientation or gender identity may restrict a person's ability to perform normal daily tasks or live independently. Therefore, ACL, even sort of by guidance, has considered LGBTQ older adults that as a target population for services and supports, because they do meet the Older Americans Act definition of greatest social need. As I said, just last year, the Older Americans Act was reauthorized and included this new language. And as a result, we will be releasing new guidance for states to use in developing their state plans moving forward. And this guidance will emphasize and build upon ACL's longstanding inclusion of LGBTQ older adults as a population in greatest social need. And we're going to be doing that through the guidance by requiring state and local area agencies on aging to describe in their plans on how they use the funds, how they will conduct outreach and education to LGBTQ plus older adults, and also collect data. In addition to sort of these formula-based grants, which make up the bulk of our funding, we do provide grants that are sort of competitively provided. So different organizations, local entities, et cetera, can compete for non-formula based funding. And we are going to be working for fiscal year 2022, which starts in October, to ensure that the administration's executive order on preventing and combating discrimination on the basis of sexual identity or gender or sexual orientation or gender identity is implemented through our funding opportunity announcement language and our terms and conditions to ensure that the agency's grants prohibit sex discrimination based on sexual orientation and gender identity. So moving beyond funding, as I mentioned, we also provide technical assistance for working with LGBTQ plus older adults. And the way we've done that since 2010 is we've supported SAGE to administer the National Resource Center on LGBT Aging to provide technical assistance aimed at improving the quality of services and supports to LGBTQ plus older adults. So a couple examples of resources they've created over the years include a resource entitled Inclusive Services for LGBT Older Adults, a practical guide to creating welcoming agencies. They've also produced a resource on inclusive questions for older adults, a practical guide to collect data on sexual orientation and gender identity. And this year, as part of their funding, they are developing a resource called Becoming a Transgender Ally, and it's going to be a best practice guide and slide deck. Beyond these sort of specific resources, they provide training to over 100. They have provided training to over 105,000 professionals from ACL-funded organizations, mainstream aging nonprofits, and for-profit businesses. And through this, they've awarded over 500 SAGE Care credentials for going through particular training on serving LGBTQ plus older adults. We also know that data is a huge issue in getting to best serve and support LGBTQ plus older adults. And so we're taking steps to both increase data and research on the unique needs of and approaches to serving members of the LGBTQ plus community. For example, we are currently engaged with the National Academies of Sciences, Engineering, and Medicine on their report Measuring Sex, Gender Identity, and Sexual Orientation. And we're looking for, when that report comes out in December, how to apply their findings and how to best ask questions related to sexual orientation and gender identity, especially among the older adult population in our national survey of Older American Act participants. Finally, I wanted to touch on HIV just a bit. So over the years, ACL has funded grants and produced informational materials specific to older adults living with HIV. And I'm going to be turning it over to Jim in just a second. And he is with HRSA. And we have been starting a new partnership with them because both agencies are aware that currently individuals over the age of 50 now make up almost half of all Ryan White HIV program clients. So as individuals are living with and surviving the HIV/AIDS epidemic, they're growing older, they're taking their medications and living their lives, they are becoming a whole new generation of older adults living with HIV/AIDS. And we need to make sure that between ACL and HRSA, we're connecting our networks of care. So we are planning joint programming to better connect our networks, the state units on aging, the area agencies on aging, and tribes, to the Ryan White care program providers in those same communities. So that is sort of the work that we're doing on funding, data, technical assistance, and in terms of HIV, both at ACL and with our partners. So with that, I'm going to turn it over to Jem to tell you a little bit more about HRSA and their work on LGBT issues.
Good afternoon, everybody. My name is Jem Doss, and I'm going to put a couple of resources in the chat that you can refer to later on. So as Brian said, I do work at the Health Resources Service Administration. We call it HRSA. And it's probably one that you've never heard of, or if you weren't in policy work, you probably would never have heard of it, but you probably would have been impacted by it. You know, we're not in the news like CDC or NIH, but we do quite a bit. So as Brian said, one of the things we do is administer the Ryan White Care Act. It's under our HIV/AIDS Bureau, and it's funny, Brian, that you're mentioning that because a friend of mine, a good friend of mine, actually does work around aging LGBT populations. He himself is a long-term survivor. I've known him for 30 years, and 30 years ago when I met him, you know, he always thought he would be dead in a couple weeks. His partner died years before I met him, and here he is now, 30 some years later, and still in the movement, and you know, addressing the needs of the aging LGBT population. So it is quite a task, and it also shows us that as things move along, the epidemic changes as well, right? It is now sort of a chronic illness, and you know, there are a lot of issues that we still have to figure out. So the Ryan White is the payer of last resort, and we serve about 500,000 people each year through the Ryan White program. And the Ryan White has been reauthorized several times. I think we've hit 25 years, if not longer, maybe 30. I'm forgetting our anniversaries, but we've been around quite a long time. So we have a couple other bureaus and offices. The Bureau of Health Workforce provides funding for loan repayments and scholarships for people who are interested in becoming a health professional. And we also fund some medical colleges, medical schools, to develop curricula around caring for LGBT patients, so that, you know, the people going through med school learn about the population and are prepared to serve them. In our Bureau of Primary Health Care, you have probably heard of Fenway Health Center in Boston and their institute, and the LGBTQ Health Education Center. So that is one of our funded technical assistance centers, and their mission is to provide all sorts of LGBT health related training, and they offer it broadly, and we fund them to be that resource for health centers around the country. The Bureau of Primary Health Care funds more than 1,000 health centers around the country, and they serve about 30 million people, which when I started in 2012, the number was 20 million. So we've increased our capacity and funding for health centers quite significantly in that time period. And some of that was funded by the Affordable Care Act, or otherwise known as Obamacare. Our Health Systems Bureau does a lot around transplantation and organ donation, and they work very closely with FDA. A couple of years ago, they updated recommendations around transplantation between two people who are HIV positive, and they do work with FDA around regulations around blood donation. The Maternal Child Health Bureau provides funding to states, and some of these are formula-based, and they are for programs for mothers, children, families. They do a national survey, the National Child Health Survey, which it doesn't ask for sexual orientation per se, but it does ask about adverse experiences, adverse childhood experiences that are related to gender bias and sexual orientation bias. So we do collect some data on that. And finally, I want to mention the Federal Office of Rural Health is a part of HRSA as well. And as you know, rural populations have a harder time accessing healthcare for a number of reasons, and rural LGBT populations also have additional burdens. And so we do have a group of people within the Federal Office of Rural Health Policy who will be publishing soon some sort of fact sheets on sort of social determinants of health and health equity issues for that population. And I work in the Office of Health Equity, and so we're part of the administration of HRSA. We work with all of these bureaus that I just mentioned to ensure that issues around health equity for various populations are part of everyday consideration, including the way that notices for funding are written. And I sit on a number of internal committees with various bureaus and offices and programs to make sure that health equity for the LGBT population is very much a part of our everyday work. So in the links in the chat, I put a link to HRSA, and then I also put a link to a report. It's from 2015 to 2016, and it's a list of accomplishments from HRSA. So we used to do these every year up until 2016, as you can see. So we haven't updated it, but I can tell you that we haven't stopped. We didn't stop any of our work in the last 4 years. We continued to provide funding for Ryan White, for community health centers, for medical schools, for the LGBTQ Health Education Center. So really our work has continued. And then one other thing I'll mention is that I lead the HHS-wide initiative called Healthy People, specifically the LGBT objectives. And we do have objectives for 2030. They're set by decade. Most of them have to do with increasing the data collection on nationally representative surveys. And what's new this decade is because of the Youth Risk Behavior Survey out of CDC, we now have objectives related to the health of LGBT high schoolers, so bisexual orientation, around bullying, substance use, and suicidal ideation. And hopefully within the next year or two, we'll also have an objective for transgender youth on those 3 objectives as well. So the way Healthy People works is that we need to have a nationally representative sample as our data. And YRBS only recently started asking for transgender identity. They released a report, I think, in 2018 or 2019. So we now have a baseline from which to set a goal for 2030. And the participants of that work group include SAMHSA, CDC, NIH, FDA. So all of the other divisions within HHS are a part of that as well. And in addition to our objectives, of course, there are other objectives in Healthy People that will track the LGBT population, because we now have data coming from the National Health Interview Survey, the National Survey on Drug Use and Health, and several other national surveys. So hopefully this will be a good decade for collecting data for our populations. Good data. All right. And that's it. So I'll stick around if you have questions later.
Thanks, Jim. All right. Last but not least, Umberto from SAMHSA.
Thank you, Brian, and good afternoon, everybody. It's a great pleasure to be here today. I'm old-fashioned, so I'm going to actually share a presentation. So let me just put this on presentation mode. Okay, so can you all see that? Okay, so like I said, my name is Humberto Carvalho. I'm a project officer at the Substance Abuse and Mental Health Services Administration, and I work at the Office of Internal and External Affairs. One of the main projects that I work with is actually focused on one of SAMHSA's strategic initiatives, which is workforce development. So, but just in case you are not familiar with SAMHSA, SAMHSA is the agency within the HHS that serves as the lead of public health efforts to advance behavioral health in the nation. So our mission is pretty much to reduce the impact of substance use and mental illness in American community. So SAMHSA, like every federal agency, we have several offices, several centers, bureaus, but I'm going to just focus here in 4 main centers that SAMHSA has, which is the Center for Mental Health, Center for Mental Health Services, the Center for Substance Abuse Treatment, the Center for Substance Abuse Prevention, and the Center for Behavioral Health Statistics and Quality. So each of these centers, they have specific missions within the context of SAMHSA that provide specific grants, cooperative agreements, and services and initiatives to support the behavioral health of all communities in the U.S. Now, the Center for Behavioral Health Statistics and Quality specifically is they lead the federal government. They are the lead federal government agency for behavioral health data and research. So they maintain several data collection systems, including the NISDA, which is the National Survey of the Drug Use and Health, which was just mentioned. So now, what's the importance of that survey? That survey it's run every year. We collect data every year from all different populations in the US. And how do you use that data? That provides, the data from the survey provides a window into the state of substance use and mental health issues in the United States population. So it actually, the data collector helps us to guide policy directions addressing many different aspects of behavioral health, including problem substance, what are the main drugs that people are using in a given current year? What are the prevalence of mental illness, for instance, among different populations? What are the intersections of substance use and mental illness health issues? And also it provides insights that can be studied in the context of data from other agencies to help in decisions making about what types of resources are needed and where resources should be directed. And what you see in the bottom of this slide is the actually URL, so you can actually go into the NISDA. So the NISDA is actually publicized every year around August, September. For instance, the one that is currently available in our website, the data was collected in 2019 and it was actually published last year. So around the end of August, beginning of September this year, you may see the NISDA data collection from last year and you have more updated data. So one of the examples of data that we collect, how we use this data, for instance, this survey in 2019 let us know that among the LGBT population, 18 plus, in other words, adults, lesbian, gays, and bisexual, about 18.3% of the population had some type of substance use disorder. You're talking about 2.6 million individuals. And among these individuals, 1 out of 2 struggle with illicit drugs, 3 out of 5 struggle with alcohol use, and 1 out of 6 struggle with both illicit drugs and alcohol. And if you look at the red circle, that data pertains to LGBT individuals with mental illness. And as you can see here, out of a population of 6.8 million individuals, about 47% of them have some sort of mental illness. And among all those individuals, 2 out of 5 have actually serious mental illness. Now, one of the most important data that we can actually, get out of this survey, is, I don't know why this keeps jumping, is, for instance, okay, I don't know why this here, let me move this bar. So, okay, so this is a graphic showing the gaps in treatments. For instance, if you look among the individuals, with substance use disorder, about 86% of them reported not receiving any service during the year 2019. If you look among the individuals with mental illness, they about 50% of them, close to 50% of them, didn't receive any service in 2019. Individuals with serious mental illness, 1/3 of them did not receive any service, and individuals with co-occurring mental disease and substance use disorders, almost like 87% of them didn't receive. So this is just to show you the importance of this data collection. I know that Brian mentioned data collection as a very important topic, and this is here is just data related to LGBT adults. So now, obviously, treatment gaps is not the only issue that the LGBT population face. So other issues, in fact, include negative social attitudes and discrimination related to an individual's LGBTQ identity, how that contributes to disparities and may result in institutional, interpersonal, and individual stresses that affect mental health and well-being. So this stress, as well as limited opportunities for support, are very common in sexual and gender minority youth and in their families, communities, and school settings, as you all know. So some transgender youth, for instance, have also issues with dysphoria. So these are just some of the issues that are also need to be considered when implementing activities to support LGBTQ communities. So for that, SAMHSA has within our structure an Office of Behavioral Health Equity and Justice Involved. So this office coordinates our efforts to reduce disparities in mental and substance use disorders across all populations, not just LGBTQ. This office, okay, I'm having a problem with this graphic here, but anyways. This office seeks to impact SAMHSA policies and initiatives by what? By creating more strategic focus on creating a more strategic focus on racial, ethnic, and LGBT populations in SAMHSA investments, using the data that we collect to inform quality improvement approaches to address racial and ethnic disparities in SAMHSA's programs. For instance, like I mentioned, all the centers, CSAP, CMHS, all those centers, they use the data and they use information from this office to focus some of their programs on specific populations, including LGBTQ. And also to ensure that SAMHSA's policy, funding initiatives, and collaborations include emphasis on decreasing disparities. So what are some of the topics that we use that we focus on in the attempt to decrease disparities? Obviously, putting a positive focus on positive family attitudes, including the guardians and the caregivers, promoting community engagement, promoting appropriate interventions by medical and behavioral health care providers in order to serve LGBTQ population, supporting optimal development of children and adolescents regarding sexual orientation, gender identity, and gender expression is vital to ensuring their health and well-being. So we consider all these points in order to create our programs. And as an example, we have created what we call the Centers of Excellence for Behavioral Health Disparities, which is a grant program that we funded last year. And this program is comprised of 3 Centers of Excellence with the mission of developing, disseminating training and technical assistance for healthcare practitioners on issues related to addressing behavioral health disparities. Pretty much is a workforce development training program. And like I said, we created 3 centers, one focused on African Americans, one focused on LGBTQ communities, and one focused on older individuals, 60 plus, the elder population. What you see in this slide here is just a quick overview of the actual Center of Excellence for LGBTQ plus behavioral health equity. The website is on top over there. I will invite you to take a stroll through this website, take a look at it. There's many interesting information there. What they do is they provide behavioral health practitioners with vital information on supporting the population of people identifying themselves as lesbian, gay, bisexual, transgender, queer, questioning, intersex, two-spirit, and other diverse sexual orientations, gender identities, and expressions. They, through this trainings and coaching and technical assistance program they implement, they are promoting change within mental health and substance use disorder treatment systems to address disparities affecting LGBTQ people across all their lives. So another interesting project that SAMHSA has invested on was a groundbreaking publication that was issued in 2015 entitled Ending Conversion Therapy, Supporting and Affirming LGBTQ Youth. This publication is actually under revision right now. And through the process of the revision, they will maintain the consensus statement against the so-called conversion therapy attempts to change sexual orientation or gender identity. You will highlight latest research and information about evidence-based programs for supporting LGBTQ+ youth and add an addendum for stakeholder consideration regarding policy opportunities to end conversion therapy and at the national, state, and local levels. So SAMHSA centers, the CSAP, and an internal group that we call Sexual and Gender Minority Interest Group that we have inside of SAMHSA. They are all part of, they serve as subject matter experts they served as subject matter experts in order to create this document. And they are also taking part on the revamping of this document along with several other stakeholders. And in fact, there's an expert panel that's going to meet next month in order to start a revision of this document. And the idea is that the final version will be revealed, will be put in, it will be publicized on January 20 to commemorate the 1-year anniversary of President Biden's executive order on preventing and combating discrimination and on the basis of gender identity or sexual orientation. So this here is just to illustrate, this is the actual document that was issued in 2015. So the top there, the top line there is the actual PDF URL you can download and you can read through this document if you have any interest. It's actually quite interesting. And again, this is the document that is being revised. So now I mentioned that SAMHSA has within our agency a group that we call the Sexuality and Gender Minority Interest Group. We call it SIGMIG, which is comprised of employees that provide subject matter expertise and professional development opportunities within our agency on issues pertaining to LGBTQ populations. So we have about like a dozen representatives from each center and offices that are part of this group. And several of this group, these individuals, they actually provide input on the development of SAMHSA's and in conversion therapy publication, and also in other types of activities that SAMHSA promotes to support LGBTQ populations. So, and one of the things that they recently did was they had like a Pride celebration event last month with guest speakers, to educate the internal staff from SAMHSA. We have old and new staff, we have a constant flux of staff coming in and coming out. So it's important to keep educating our staff so that they can actually promote great ideas for implementing programs to support LGBTQ populations. So this is just in a nutshell, this is just a very quick overview of what is it that SAMHSA does and how we do, with the appropriations that we receive and with the data that we collect in order to support different populations, including LGBTQ populations. So thank you.
Thank you, Humberto, and definitely bringing my work full circle. I actually got an email from Arlen, who's leading the conversion therapy report revision while you were talking. So it's great to see that work continuing. I know Stephanie did have to leave a little bit early, and Sarah messaged me that she was going to have to jump off and was hoping to come back for question and answer session at the end, but I haven't seen her rejoin yet. But Jem and Humberto and I are happy to answer questions, or if you want to type a question in a chat for Sarah or Stephanie, I can sort of copy and paste it and email it to them. And the last thing I'll just say is also, we represent obviously just a portion of HHS. If you have questions or comments about other parts of HHS, I don't know that any of us will be able to respond directly with the most latest information, but I can either try to help or reach into those organizations and get back to folks as well. So Steve, if it works for you, we can either see if people have questions verbally or in the chat.
Yeah, I would go ahead and speak up if you have questions. We've got about 15 minutes here.
I have a question for Brian. Well, first of all, thank you all for this wonderful sharing of your work and the nature of your organization. My question is regarding COVID-19, and we're still pretty much in it, right? And then we all know that the older adults seem to be the group that are the mostly impacted. So I wonder whether the funding paradigm that you mentioned or the initiative that were ongoing during this period, whether you have to make certain kind of changes because of the COVID-19 and the type of challenges that you encounter.
Certainly, you know, I think one of the main things, in addition to the obvious sort of unprecedented toll on older adults, especially those who were living in nursing homes at the time that the outbreak began, is, you know, for those who either have survived or lost loved ones, et cetera, one of the main issues has certainly been social isolation. And how do you overcome the social isolation of older adults who, you know, have gone through this epidemic? And so, you know, we have been blessed by Congress with additional funding for all of the programs essentially that we run during the COVID pandemic. And there has been a strong emphasis in particular on the social isolation aspect and what we can be doing to reduce social isolation among the older adults. You know, and we have obviously seen sort of interesting and innovative ways that the Aging Network has responded. So, for example, you know, obviously they were being shut down from congregate meal opportunities, but those sites have turned to things like grab and go, eating in the parking lot, you know, Zoom-based get-togethers. So there has been some positive innovations in some of the programs. You know, I think, you know, on sort of maybe a potential flip side, it has obviously been very hard for the long-term care ombudsman to come into nursing homes and investigate complaints. They've tried to adapt the best as possible as well. Also sort of like well-check visits that used to be well-check visits in person. A lot of the local area agencies on aging have had to, you know, convert to sort of wellness checks by phone. But of course, you know, there's sort of in rural areas that can also make it easier on everybody. So I think there's no doubt that there's been extreme toll on older adults, particularly those in nursing facilities and other congregate settings. And there's sort of nothing good about the loss of life, the toll that has taken, and the social isolation that's been experienced by essentially everybody in America, but especially older adults, you know, if they live alone, et cetera. You know, I think one particular thing to bring it back to the specific topic, and then I'll move on, is that LGBT older adults tend to already pre-COVID be much more socially isolated than a lot of their counterparts, in the sense that, as we are all aware, the generation of older adults now are not legally allowed to be married. Many, if all of them, did not contemplate having children. And so they don't have the mechanisms of support, even pre-COVID, that many others rely upon for caregiving and wellness checks and visits, et cetera. And so there has been an extra toll, I believe, on the LGBT older adults as well, because they don't always have the same natural caregiver support systems that other folks do.
Thank you.
That was an excellent question. Go ahead.
I have a question as well. I think, so yeah, first of all, again, thank you. I really appreciated hearing from you all more directly, because sometimes, like, yeah, policy work can seem just like so like out there, amorphous. And so listening to people who do work, it's really exciting. I think one of the things I'm wondering, so I'm a nurse. One of the things that nurses, I think, struggle with for sure is like, but also have, like, when they do speak up about things, have a lot of impact. And usually it's through like nursing organizations. And I think I was just wondering what advice you have for like healthcare providers who aren't like directly involved in policy work to like find ways, because it's like, even for me, like even like whether or not I end up in a position eventually that has like more direct policy implications, you know, how do I as a nurse, how do my colleagues reach out and connect with people at HHS or SAMHSA to like speak about the issues we care about in a way that we feel like will actually be heard? Like, what is the most effective way from y'all's end that we could do that?
Well, let me just take a stab on that question. So, okay, so I personally, you know, like I said, I manage several training and technical assistance programs, not only for like the Center of Excellence for Behavioral Health Disparities, but also for many different areas related to behavioral health. So I receive questions from the public all the time and reports from the public directly to me. They email me. And I collect all that and I pass that to my leadership, saying, you know, and sometimes, you know, for instance, especially when COVID started, that a lot of people start contacting saying, oh, I no longer have access to my medication. I no longer have access to my provider. So how can I do? And then, you know, SAMHSA quickly start moving the wheels in order to address, you know, the issues. You know, one of the things that they did was, like, for instance, they quickly moved the 42 CFR Part 2 regulations to they flex that in order for individuals to be able to do a quick check-in using platforms that probably wouldn't be, you know, allowed during pre-COVID. So, and, you know, that things like that, you actually can, you know, just reach out directly to agencies like SAMHSA and others and HHS. But you can also use your associations, like you mentioned, the nursing associations, which to me is your, you know, is your collective voice of your profession. So that you should obviously contact with them and express, bring to their attention specific issues that you think that they should be working on advocating, because they can actually go to Congress, they can go advocate for specific issues and specific resolutions. So, but so, you know, you actually can reach out direct to us.
So I'll add, I just put a link in the chat to the, I don't remember what they're actually called. So the National Advisory Council on Nurse Education and Practice. And we also have the National Health Service Corps Advisory Board. And these are secretary level advisory councils, which means they are, you know, they're official, they are citizens, they're not employees of HRSA or the federal government. They're the representatives of the practice, and they come together to advise HHS and HRSA in particular around, in this case, nurse education and practice, but also with our National Health Service Corps. So these are official bodies. They, you know, have official meetings. I've actually addressed them both, and there are a number of topics that they address each year. I know that, for example, the Nursing Advisory contributed to the National Academy's recent report on the future of nursing. And so there are these pathways to get something on the agenda.
Yeah, this is Brian. I agree with both what Jim and Humberto said, and just to sort of give an additional concrete example, you know, Humberto mentioned the Ending Conversion Therapy report, which we did in 2015. They're updating. The American Psychological Association was a tremendous partner. We ended up creating that document through a public-private partnership, whereby the American Psychological Association actually hosted the meeting where they came to the consensus on the 13 consensus statements around ending conversion therapy. And so SAMHSA's partnership with the American Psychological Association was sort of one of those true public-private partnerships that advanced a policy. And certainly, you know, APA included individual members in that effort. There are Office of LGBT Affairs within APA. And then we gathered as part of that panel who came up with the consensus statements, other individual providers from psychiatry, social work, marriage and family therapy, et cetera. And so those individual healthcare providers served on this panel that came up with the recommendations that are in that report. And so their voices are always extremely valuable. And I think as Jem and Umberto said, both individually and through their national associations.
Thank you all so much for those answers. Yeah, I was like, and I'm really intrigued by the committee information that you sent, Jem, as well. I think I looked now that one of the nursing council members is a provider at my institution. So I was like, oh, I might shoot her an email. I looked real quickly. I was like, that works out well. So I'll definitely be reaching out to her and asking about that. Thank you for that. And thank you all for all the awesome information. I think it's hard when numbers are so big in the nursing profession to feel like any one nurse has that like individual opportunity to like bring forth their concerns. But I think in reality, it's like this illusion because I think not enough of us come up and say something because we all have that like bystander illusion of like someone else is saying something about that. So I think like trying to learn those pathways and like, I think, doing this program, I'm like looking to find ways to be a nurse that tells other nurses how to do that, if that makes sense. Like less so that it's like, oh, like I have XYZ thing I want to say. It's like, I know other nurses certainly do. And I would like for them to say something about it because they have more experience than me, or they know more about XYZ thing than me because I'm very early in my career. So I'd love to help them find ways to speak up about it. So thank you.
Yeah,
I wanted to add that you're, yes, there are, however millions of nurses, but it sounds like you're going to be well placed and you already know someone who has an influential position. And, ultimately policy work is about the relationships you build, right? And those relationships become conduits for the changes that we want to help motivate.
And I would just add, I have worked with ANA and several other nursing sort of associations in the past, and essentially all of them, as you probably know, do like a Capitol Hill Day, where you can come. And while that is, the legislative branch, and we're here on behalf of the executive branch, if you're here in DC doing a Hill Day, that doesn't mean you can't also request a meeting at HHS to talk about a particular issue. Also, I don't know as much about ANA, but like other organizations like American Psychological actually have Hill Fellowships where you compete and then they'll place you in a particular member of Congress's office or a committee office to learn more about the policy process as well.
These are all really great questions. I appreciate it. I'm gonna, even though we're at time, I'm gonna steal a little bit of time to ask a question since I've got this gang here. And last night we had our LGBT Health Forum on Aging in the LGBTQ population, and you provided some wonderful supplementary information for that. And I apologize, my camera's not on. I'm actually uploading the recording of that right now to YouTube so we can publish it and people can see it. So my bandwidth challenge, so I turned my camera off. But anyway, wonderful complimentary information. And Sylvia Fisher, and at the end of the call, and I called on her to sort of give her provided some terrific information. And I go back with Sylvia when she was in SAMHSA and working with Gary Blau, and during the and Brian, you know this, certainly during Bush 2, we were flying below the radar, what we thought was the most oppressive environment we could possibly experience, but then along comes Trump. And anyway, that they started, Gary and Sylvia started the LGBTQI2S task force, which was a group of external advisors and experts, and I was on that group with her and with many other people, Caitlin Ryan as well. I mean, wonderful group of folks. And I know that group has sort of become inactive. And I've heard, I think you mentioned earlier that SAMHSA now has a sexual and gender minority, office or effort. Is that sort of supplanted the LGBTQI2S, pardon me, effort, or is that still ongoing in some other way, external input?
Sorry, you're talking about the Center of Excellence that I mentioned?
Yes.
Okay,
Exactly.
that Center of Excellence was just funded. It's a grant for 5 years. That's a professional development focus center. So the idea is that center will help communities, all providers, and even the audience, consumers all over the U.S., like peers, to better implement strategies to serve LGBTQ communities. So obviously, culture and acceptance, and having the use of specific interventions that are applicable to LGBTQ individuals is actually very important in order for the individual to feel safe to receive treatment, or even to engage in treatment, or even to admit or to seek treatment. So especially when you talk about individuals with substance disorder and mental illness. So, the idea here is that, this program is going to try to reach out to as many professionals and professional organizations as possible to bring innovations and bring in new training opportunities for those providers, so they can actually become more culturally acceptant, and they can become culturally sensitive, so that they can provide better service and better understand the public that they are serving. So this is a grant program that was funded for 5 years. So it just started. It's actually the recipients, the University of Maryland in Baltimore. So they're the ones who obviously have like a whole set of partners. They're not doing that alone. So, and they promote all this set of activities and training opportunities, and and they have a portal where you can actually provide comments and suggest activities that they should implement and develop. So, and they're pretty open to receive. They do yearly needs assessment, but they are pretty open to receive suggestions. So,
Yeah, this is Brian. I think
it's great to hear about that.
I think
Go
it's
ahead.
I think it's taken on, and I think even University of Maryland School of Social Work was the last contractor for the LGBTQI2S work group. So I think some of that work has transitioned in a similar way, and I think also, though, at times it's not the exact same thing, Steve, but it's I think it's my understanding is it's trying to accomplish many of the same things. And I know that Humberto mentioned that he works with the SIGMIG, and Amy Andre, who was the last sort of project officer for that work group, is engaged in the SIGMIG work. So there might be some additional ways to sort of connect the two in the future.
Well, it's great to hear about all that. And I see that Jem too also put something about the LGBTQ employee assistance group in the chat too. So that's great to hear about. I apologize that my question pushed us into an additional 5 minutes of time, but I want to thank everyone again. You guys are really terrific for having done this. It's really wonderful to see things getting back on track after a little bit of a pause and a little bit of panic mode for a while. I'm going put the evaluation link again into the chat so our students can complete an evaluation on that. This has been wonderful. We'll do this again, hopefully in person, and we'll come back to Humphrey again for the first time in a while. And that would be that. I really can't wait for that next summer. And I'll remind everyone that in an hour and what time? We have 2:15. I think we have the alumni new student mixer coming up. So I've sent a reminder out to our alumni, and you all are here, and I can remind you about that too. This will be your opportunity to chat with some alums, and hopefully they'll be able to take time off of work to dip in and say hello. So make sure to come back for that. And that is scheduled, I believe, for 2:15, and that'll go till 3:30. After that, there's time allotted for a student debrief where you can the events of the past few days. And then at 4 o'clock, please remember to come back in. We're meeting with Erin Dugan, who is Senator Baldwin's senior policy advisor at 4. So she will be there to brief us on what the senator is currently involved in with stuff up on the Hill on the legislative side. So time again, thanks you all. And I'm going to go ahead and stop the recording right now. And